think all right. Where was I? Yes, so as I was saying, there's something else going on this CT scan. You realize that aside the bleeding that is seen here, the acute bleed here, you realize that the ventricles are also not looking fine. Now, if you look at, you realize that the midline is shifted. Look at this midline here. The far cerebri is right in the middle, but over here it is shifted away. So it's moving the ventricles also away from the site of the bleeding. So this person has an acute subdural hematoma with pressure effect. So there's a pressure effect here. So the bleeding here is expanding and is pressing the brain matter to the other side. So such a patient needs emergency surgery, bare hole and drainage. Otherwise, it's likely to die. I hope you can all see that.
Yes, doc.
Yes, doc.
Okay. All right, so that's about it. So there's a pressure effect here. They cause the ventricles to suppress. So this pressure effect, if you don't have surgery for this person, you die within a few hours. Okay. So that is what I'm saying. I should be able to pick up these things, assuming you get a CT scan and you have this picture, and you are sitting there waiting for a report. Report number, report number. By the time the report will come, the person will be dead. And then you write that acute. And then you be looking at it, and you realize that actually this one you are the one who has killed the patient. So take note of these simple ones, which are very easy to spot on a CT scan. Right. So another bleeding type that you might see, usually in the case of trauma, what do you call it? Is epidural hematoma. Now, what difference do you see between this bleed and that bleed? This one, you can see it here. This one, you can see it here. What difference is that between this? Somebody answer quickly. I'm waiting.
Doc, please come again, sir.
So can you move to the next one?
I'm saying that compare this subdural to this, the bleeding here. What can you say about the bleeding here compared to the other one, the way it looks?
Sir,
Yes.
I think with the second one, it seems there is a breakage of the scar.
Okay.
So there is a leak.
I'm interested in the bleed. How does the bleed look like?
Oh, it is an acute one. Acute
Yes.
subdural.
Again. All right. So you see that this bleed here, it follows the contour of the scar, doesn't it? Look. Right? But the one here, it is not following the contour. Look at the edge of it. Can you see? Here. Can you see?
Yes, doc.
So the reason you need to know these ones are because they have serious implications. All right. The epidural hematomas, because the bleeding is occurring above the dura, it usually occurs like this. So you see more like an orange versus the subdural, which is occurring below the dura. And so it just flows, covers over the brain, sort of. So that one appears more like a banana. It follows the contour of the skull, whereas the epidural will not follow the contour. And epidurals will kill a patient faster than a subdural. People can have subdural for a long time and not show any symptoms. That is why I want you to, if you see an X-ray like that, it's, it's just a matter of hours and the patient will die. Okay. So take note of this. Okay. Now there's another picture that shows how the hemorrhagic strokes will also look like. So those ones, you see the bleed inside the parenchyma itself. Okay, usually inside the parenchyma, and sometimes spread into the ventricles. And as we said, of course, it's an acute something. So you see that this bleeding is acute. This bleeding is acute. And in this particular picture, you realize that some of it has spilled into the ventricles. Can you see the blood in the ventricle here? I see the level here. The
Yes.
it's up here, and the blood has collected. Can you all see?
Yes, doc. I say yes, doc.
All right. And this is how an infarctive stroke would look like. So there will be areas of hypodensity. There will be hypodense areas. So that's how a CT scan of hemorrhagic, an infarctive stroke look like. I hope you can all see that.
Yes, doc.
So the thing is that, so basically, if you have someone who you think has a stroke and you are contemplating whether to start antiplatelet or not, when the CT scan comes, I mean, you've done it within a few hours of onset, and you are not seeing white indicating a bleed, then it's more likely infarctive if you are seeing dark areas. So you can go ahead and start your antiplatelet. I hope this is clear. Is it clear?
Very clear, sir.
Yes, doc.
All right, so what are some of the benefits? So benefits include a painless and non-invasive and very accurate. Yeah. And then it's also able to image bone, soft tissue, blood vessels, all at the same time. So with that one image, you're able to take all of that. And it provides very detailed images. And it's also, unlike MRI, where the patient has to be completely still, this one is not as sensitive to movement as MRI. Okay? And then it provides real-time image. That is how we're able to use it for biopsy. And also, there's no radiation remaining in the patient after the, what do you call it? What do you call it? I mean, there's no radiation remaining in the patient after CT, so it's good. Yeah. So what are the risks? Of course, for radiations, there's always a small risk that patient might get a cancer. And it's also not recommended for pregnant women. If you must do it well, then you need to use shielding. And then it's also not very common for you to get a serious allergic reaction. And then it's known to sometimes cause cataract. All right, I think that's it. Okay, so any question? Shall we end?
Yes, Doc. I think we
Part of
can.
the CT scan recording.
Yeah, good night.
Oh,
Okay, now hold on. There.
hold on.
Right, okay. We have it. There was,
Hey, me.
I made some additions to the seats I wanted to draw attention to. So I don't see it in exams and you probably need this. Where is it? I think it's this one. Have you all received the slides? Have you
No.
received the slides of the
Not yet,
ultrasound?
Doc.
No, Doc.
No.
Huh?
That
No,
is
Doc.
for the that's for the regular class.
No,
Weekend
Doc.
all received it. Weekend has
Ah,
received it.
why? But I shared to both yesterday, class reps. I don't like that.
Doc, the weekend class have
I haven't
received it.
received it.
Those saying no
All
are
right.
for the regular class.
Yes, but regular class, so what's happening? The class reps, where's class rep?
It just came. He just posted it.
Oh, why? Please, when I share things, send them promptly. I don't want any excuses coming in. And I did this here and I did this. Yeah. Class reps, please. It shouldn't happen again. The moment I send it, whether it's 12 p.m. or 1 p.m., forward it and be free. Yeah.
We just received it 8-7.
Where is it? No, this is not the one. Okay, so I've added the various pictures of the probes. Okay, so when you see any of them, you should be able to identify it. So if I bring pictures of these, the applications, all right. Or even if you have to list them, if you are not to identify, right, you will use the same thing. Then I added the endocavitatory probe. Now this probe is what we use for transvaginal scans. So these ones, we put them in cavities. That's the endocavitary ones. So if we can you all see the slides, by the way? Can you see the slides?
No, Doc.
No,
No,
Doc.
sir. No, sir.
Okay, so someone is asking whether CT is there when you want contrast. You should write it. Yes, if you write for contrast, they will do it. But because you are not the expert in the various pathologies, if you tell them what you are looking for, the radiologist is the best person to determine that for such and such a condition, a contrast will be better, and they'll go ahead and do it for you. I hope you understand. So if you know that this test requires contrast, it's all right to write it. But if you don't know, if you give a good history and differentials, they will decide whether you need contrast or not and go ahead and do it. So, Mr. Pashiga, I hope I've answered your question. All right. Then the next thing is, yeah, so as I was saying, so this is what you use for transvaginal scans. That's the endocavitary. That's what I've added. So take note. If you see it somewhere, don't say you are not aware. You are aware of it. Right. And then also I've added here ultrasound guided biopsy. So,
I'm not seeing.
No picture.
Doc, we are still not.
Doc, we are not seeing it. Oh.
yeah. Namonke.
Oh, Doc, you can defer. So question in the between.
Oh, man. Okay. Can you see now? Can you see the slides now?
Doc, we can
Yes, sir,
see
we can see.
the slides moving.
Is it moving now?
Yes, Doc. It's
Oh,
moving now.
okay.
Yeah.
Can you see?
Yes, doc.
Yes, so can you see the picture of the proof now?
Yes, doc.
So this is what I'm saying. So, so this is what I'm saying is the one that is used for what do you call it? For transvaginal scan, for instance.
Hey.
Okay, so this is more sense. I mean, you get to learn the applications. This will pick up a pregnancy much earlier than a normal curvilinear scan will do. You get it? Eh? All right, so that's one thing I've added I wanted you to note. So I've added that also here. So it's mainly used for gynecological applications. It picks up ectopics much earlier than the ordinary. Then I've also added that we use it for ultrasound guided biopsy, just like we do for CT scan. We use scan ultrasound for the same thing. Okay, I think I've added a few more applications. Then I wrote also, there's some of the limitations, yes. Now, one limitation of ultrasound is that it doesn't penetrate bone. When there is gas, it makes it more difficult. Also, for someone who is very fat, sometimes it's difficult for the ultrasound to see deeper tissues. And a major limitation, or the most major limitation, is that ultrasounds are operator dependent. Ultrasounds are operator dependent. So someone will be able to give you better results and better reports if the person has the experience, the person has the training, the person has the knowledge. That is why it's not any incontinence scan here that you should do, because now people set up scans and all of that. I remember a few months ago, a patient was sent to the gynecology clinic with a mass, supposedly having a mass in the abdomen that they thought was fibroid. And she came in with a scan that she had done somewhere. I don't want to mention it. And the person said, so I'm for something. Meanwhile, the person was 5 months pregnant. You see, so the person doing the sonography for you is very important. So if you should be mindful where you send patients to request for scans. Don't send them to any branching. Just anybody trained on the job to do scan for you. No. Anyone doing a scan for you to take decisions should be someone who is qualified for it. Minimum is a BSc sonographer. But even then, their results will not be compared to a radiologist. So radiologist scans are what you should aim for. But in the absence of that, you can get the BSc radiographer. Below that, you're on your own. So that is what you should do. It's very important. When you start practicing, you realize that actually they will give you some scan and you go and do something. Because that patient I'm talking about, she came in with inability, her menses was not coming. So we're actually going to give her medication to cause her to bleed. So assuming if I had just relied on the scan that she brought without doing clinical, I would have caused an abortion. And there's someone who was looking for a child, so she's worried about her menses. Can you imagine? So you should be very, very careful. As for sonography, now because you see the problem is that the machine is not expensive. So now everybody is able to buy some and put it somewhere and be doing scan. Unlike a CT scan, which is more expensive. So be careful where you send your people. All right. And then also, in CT scan, there's something called a scout image. So because we take the image in slices, the radiologist is able to quickly scan through and look at the various areas of pathology before they actually print out the images. That's what we call scout image. But in ultrasound, we don't have scout images. Yes. So I think those are the things I wanted to highlight. And yeah, so there is So these are just some, should I say, minor risk per se, right? That is illegal. So the probes can produce some heat. Sometimes it becomes warm. you know, I mean, no big deal. Sometimes gases can dissolve out of solution, but these are very rare things. As of the heat, it can develop. That might cause some small discomfort, but not strong enough to burn the person. Okay. All right, so that's it. That's it. So make sure that I think the slide that I sent to you is the updated one. I think it's about 30 slides. So please confirm that the ultrasound slide you have is the 30 slide one. All right. So God willing, tomorrow is when? Saturday. Tomorrow morning, yes, tomorrow morning we have to meet at what do you call it? Should we meet tomorrow morning?
Doc, you said we will, and then tomorrow evening.
So I'm asking, should we meet? We will meet at we have to wake up early and meet at 7 o'clock to 8 o'clock. Then we'll meet again in the evening. Around 6 p.m. thereabout.
Okay, Doc.
No, no, but we didn't receive the trial question through.
Hey, Charlie, I'm working on it too.
Yeah, so
I'm working on it.
No, all is well. The trial question, all is well.
Pardon?
I mean the trial question now. We are still waiting.
I'm working on it. And then the rest of the ophthalmology too, I'll try and see if I can send it tonight. Hey, I said my boys are doing. So it's equal. We shall. That reminds me, I understand there's someone in this class from town called Klepe. Who is that?
Doc, from where?
Klepe. The person should know herself.
It's me. Say, do by Evans.
What?
Clipper.
Your name is what? Your name, I didn't get the name.
Doc, he says he's Dogbe Evans.
Do by Evans, yeah.
Okay. So you take my number and call me. Let me find out.
I want. Okay.
All right, good night.
All right, good night, Doc.
No,